is Dr. Rahul Prasad. He will speak on a review of hypertensive retinopathy and chorioretinopathy.
Thank you, sir. And a very good morning. At the onset, I would like to thank AIOS Scientific Committee for giving me this opportunity to present my topic. So just to recapitulate, hypertensive retinopathy is a condition characterized by a spectrum of retinal signs in people with elevated blood pressure. It was first described by Marcus Gunn in the 19th century. A lot of things have been reviewed and understood much better in the recent times. Now, basically, there are three main causes due to hypertension that occurs in our eye. First is the retinopathy, second is the neuropathy, and the third is the chorioretopathy. Hypertension is also the major cause of branch retinal vein occlusion, central retinal artery occlusion, retinal vein occlusion, and central retinal vein occlusion. Coming to the epidemiology, hypertension is a worldwide problem that affects almost 1 billion people worldwide and its single most important modifiable risk for stroke. It's more common in African Americans and the Chinese descent. The incidence, if we see, in less than 45 years, it's usually the men who are more involved, and greater than 65-year-old, it's women who are more prone to develop hypertension. Now, etiology of hypertension can be briefly summarized into 3 parts: primary hypertension, essential hypertension, and secondary hypertension, which occurs due to secondary diseases. The risk factors include obesity, ethnic, stress, family history, alcohol, and tobacco use. Now, the major risk of atherosclerotic hypertensive retinopathy is the duration of the elevated blood pressure. And the major risk for malignant hypertension is the degree of blood pressure over normal, and the genetic influence does have a very positive role. Now, it's necessity of identification and documentation of hypertensive retinopathy because it is an indicator of systemic morbidity and mortality. Mild hypertensive retinopathy signs such as generalized and focal retinal arterial narrowing, arteriovenous necking are weakly associated with systemic vascular disease, whereas the moderate hypertensive retinopathy signs such as isolated microaneurysm, hemorrhages, cotton wool spot are strongly associated with subclinical cerebrovascular diseases, which predict incident clinical stroke, congestive heart failure, and cardiovascular mortality. So, hypertensive retinopathy is the result of hypertensive retinopathy is basically due to 2 causes. First is the vasospasm, which occurs due to acute effect of the systemic arterial hypertension. And second is atherosclerosis, which is actually the chronic effect of hypertension. Just a couple of points about the pathophysiology. It is the chronic hypertension that leads to atherosclerosis, and the atherosclerosis predominance, which leads to narrowing of retinal arteriole, that leads to ischemia, hypoxia, increased capillary permeability, and that leads to focal retinal edema, hemorrhages, cotton wool spot, and the heart exudates. There are different phases of hypertensive retinopathy. The main phases are vasoconstrictive, sclerotic, and the exudative phase. In the vasoconstrictive phase, there is an elevated luminal pressure that leads to a local autoregulatory mechanism, which causes retinal arterial narrowing and vasospasm due to increased vasomotor tone, consequent narrowing of the retinal arteries, and the reduced blood flow. It is the initial response to the hypertension. The clinical finding includes generalized vasoconstriction. Only a particular vessel can undergo constriction, which is called focal vasospasm and focal vasoconstriction. In the sclerotic phase, due to persistently elevated blood pressure, there is layer of endothelial wall that undergoes changes such as intimal thickening, medial hyperplasia, and hyaline degradation that leads to worsening of the arterial narrowing. The clinical findings include the diffuse and the focal retinal arterial narrowing, arterial wall opacification, which leads to silver and the copper wiring, compression of the venules by structure changes in the arteriole, which is also known as the AV nicking or nipping. The arteriovenous signs includes the Gunn sign, which is the tapering of the veins, the Bonnet sign, that is the dilatation of the veins distal to the AV crossing, and the Salus sign, that is deflection of the vein. So you can see the Salus sign, the deflection in the first picture. The second sign is the Gunn sign, where we have got the tapering of the vein, and third is the Bonnet sign, which is the banking of the vein distal to the AV crossing. Then we have got the exudative phase, which is occurred due to the chronically sustained blood pressure elevation in the blood-retinal barrier is disrupted. The pathological findings include necrosis of the smooth muscles and endothelial cell, exudation of the blood and the lipid, and the retinal nerve fiber ischemia. So the clinical finding includes microaneurysm, retinal hemorrhages, cotton wool sword, and hard exudate. Then we have got the malignant hypertension that can cause papilledema, which is a result of both leakage and ischemia to the arterioles. Then we have the hypertensive chorioretinopathy, which is rare but can occur as a result of acute hypertensive crisis, which is also known as accelerated hypertension, where there is a sudden increase of the blood pressure above 180 by 110 millimeter of mercury in young adult, leading to sudden ischemia of the choroid. And these have effect on the retinal RPE cells in the retina. So we have got fibrinoid necrosis occurring on the choroidal vessels at the level of the choroidal capillaries, poor segmental infarction of the choroid, and that leads to poor perfusion. Signs of hypertensive chorioretinopathy include Eskin spurs, Steger streaks, pigment epithelial detachment, and exudative retinal detachment. This is an example of the Eskin spots. These are cigar streaks, detachment, and the optic neuropathy. Then we have got the optic neuropathy. A very important part of hypertension is also seen in pregnancy, which is eclampsia of pregnancy. So symptoms include eye pain, headache, and reduced visual acuity. So clinical diagnosis, there are different classifications given. Among the most commonly used is the Keith-Wigner classification. The recently Wong and Mitchell classification does have got advantages, and very recently optical coherence-based tomography uses subretinal fluid as a marker for its classification. So recent advances does include the provisions of AI, which leads to better understanding of the vasculature. Management is primarily focused on reducing the blood pressure, and it is the timely evaluation and the management of reduced ocular and systemic damage. Thorough history is vital for proper and timely treatment. Complication does include central retinal vein occlusion, branch retinal vein occlusion, and microaneurysms. So prognosis is with severe hypertension, retinopathy, and atherosclerotic changes are at risk of coronary disease. Mortality of the patient with untreated malignant hypertension was 50 in 2 months and 90 in 1 year. So important is to diagnose and treat hypertension as soon as possible. Thank you.
Thank you, Dr. Prasad, for a comprehensive paper on hypertension. Thank you.